Welcome, everyone, to the Circle of Care webinar sponsored by University Hospitals Kingston Foundation. My name is Evelyn Mason, and I'm the past chair of the board of UHKF. Thank you all for joining us, and I hope everyone enjoyed the solar eclipse yesterday safely. This webinar is being recorded and will be available on our website and YouTube channel after the meeting. We expect the webinar to last approximately 35 to 45 minutes, and there will be a time for questions at the end, but you can ask a question at any time during the webinar using the Q&A feature on your computer or tablet. You're here because you're among our most valued donors and volunteers. We thank you for your continued generosity. Circle of Care events are held several times each year. Their purpose is to provide donors like you who are at the champion or ambassadors who care annual giving level, our monthly donors, and our evergreen members who confirm the legacy gift, a special opportunity to connect with some of our outstanding healthcare and research professionals, and today is no exception. We're very fortunate to have Dr. Michael Leveridge, Associate Professor in the Departments of Urology and Oncology, and KHSC Urology Department Head. He completed his medical degree at the University of Toronto, followed by urology residency at Queen's University. His clinical focus is urologic oncology, in addition to a general urology practice. His research interests include the use and value of social media in urology, as well as population-level research in bladder cancer and testicular cancer outcomes. Welcome, Dr. Leveridge.
Thank you so much. It's really my pleasure to be here, and thank you. My gosh, I'm seeing 70-odd attendees, so it's like giving a lecture to the medical students. So I really do appreciate you, and to echo those words from the UKHF mothership. A lot depends in a public system like ours on your giving spirit and your energy towards this, and you're obviously a select group. So my thanks as a benefactor for my team here in the Department of Urology, and we all thank you. I am a urologist, and so I've elected rather than a bleeding edge high tech talk. It always occurs to me, when I'm meeting with trainees, even people who are already in a medical school, who have sort of reached some kind of gauntlet of thinking about their science, that urology, my discipline, is a bit of a black box. And even though we spend a fair amount of our time doing things that we don't talk about at the dinner table, including elimination of our wastes, it kind of is taken for granted. And I'm not going to dare scan the list of names, but I imagine any list of any group of people above about the age 35 have spent a bit of time thinking about their urination and the time here and there. And so what I thought I would do would really just do a little bit of a brass tacks overview of what it really means to urinate. It sounds like exactly the kind of, hopefully you finished your lunch type of topic. No gory pictures or anything like that, but I think it's time for to open the books, and it's a reasonable thing to have a frank entreaty into why we pee, what we do, and what is actually happening. Because when we think about what actually happens, and it is certainly not as simple as walking up to the bathroom and having at it. It gives us an underpinning as to why things may go wrong, and why, for someone, no doubt, in this group, that urination is sort of the dominant thing. I will say that much of what I'm saying has to do with the setting in which there is a bladder in place, and not everyone who urinates has a bladder in place. There are technologies and there are reasons for those not to in some cases, but the production of urine just the same. So I'm going to share my screen now to show that we're talking about urination here. And you may recognize the schematic of a bladder there in the center of the screen, and you may be puzzled why there's a brain on the left side of the screen. And I'm going to go into some pains today to explain that the brain really, and the nervous system really, underpins a huge amount of what we're talking about when we're talking about urination. And that can really be a thing that dominates. So I'm even going to show some slides with some brains and some nerves, etc. I'm pitching this, believe it or not, at a reasonable level that I like to try and make sure in my practice that I'm getting my partner patients on board with. I think building a mental model and having some understanding of the underpinning biologically of what we're talking about in clinic when we're partnering in our care goes a huge way to understanding some of the rationales behind what is happening and behind what we are choosing to do about it. And so that's the cadence of the day. But I'm going to zoom out before a drop of urine is made, before a drop of urine hits the bladder, and then hopefully hits a place that you intend it to. Why bother in the first place? What is eliminating waste about? Well, what happens, of course, is that everything that we take into ourselves, whether through breathing, through ingesting, through our medications, and all of the processes inside us, which we'll call metabolism overall, all of these things generate some waste. Here is my friend ChatGPT generating a giant factory with some models of the kidneys on top of it for me as an analogy here. A factory makes products, but it has byproducts as well. A kidney and your kidneys make what we call homeostasis. That is the functioning of your body, your fluids, your toxins, your electrolyte levels, the things that allow us to stay from a wiring and plumbing perspective intact and functioning. But there are waste products from this. And so even though as a urologist, I'm all about the bladder, all about the prostate, all about the peeing, I have to defer to my nephrology colleagues and the kidneys that most of us have within us functioning well in order to provide the substrate for my life and my career. So the kidneys are the factories that produce homeostasis and as urine as a byproduct. And the urine is then made, sent down from the anatomy perspective down towards the bladder and out into the world. But why not just have something like our lungs that we can breathe out? Why not create crystals or something like our bowel movements and have our ability to deposit those? Why would we need to pee or void? And I'm going to use those terms interchangeably, voiding, urination, and peeing. You could hypothesize. Thank you again, ChatGPT. It's not easy to find a picture of a wolf peeing. You could hypothesize that the ability to mark one's territory is an important thing. And the ability to do that requires depositing something with a strong scent around it in a place where it can work. And that scent ideally shouldn't be too foul for the area around. Or perhaps if we're going from an evolutionary perspective, and I'm talking human evolution on the picture on the right with a crude cave, but really any creature's evolution, it's nice to be able to transfer our waste products away from our food and away from our housing. And so the ability to store waste in our body and deposit it somewhere else when we need to carries a huge amount of advantage in terms of sanitation and livability for creatures. So a couple of evolutionary biology hypotheses why we would even do this and why we didn't involve some other system of eliminating our wastes. The urinary system, we call it the upper urinary tract and the lower urinary tract. The upper urinary tract is where the urine is made, up in the kidneys. And that urine, once the kidneys have done their work, and we're into my world, the urine is deposited into what we call the collecting system. And this is the area up in the top. You'll see names like renal, pelvis, and ureter. The urine is collected in there, and it's not just a straw or a stovepipe that transfers things down. It's an active tube that propels things down. Those kidneys do a lot of work, and they require a certain amount of pressure. Things have to flow out of them. And if that dam backs up, or if that chimney backs up at a factory, then the effluent is stuck there. So the ureters actually propel the urine down towards the bladder and then into the bladder. I will say bladder pictures like to show big air pockets in there, but it's not actually true. It's just the urine in the walls of the bladder, unless you have an infection or something. Now the bladder will collect the urine, and this is the urinary tract, and then on out into the world through the urethra. Let's zoom in even more detail so we can understand a little bit more of these underpinnings. And these are actually super important points. When the bladder is entering down from these ureters in the kidneys into or the urine is entering into the bladder, there's a couple of valves down here. And these valves are narrow areas that squeeze the bladder as the bladder fills, and the ureter therefore is plugged off, just like you would stepping on a hose to stop a flow if it was laying on the ground. This is important because it allows this bladder to fill and accommodate some pressure without squirting urine back up to the kidneys. Remember, and I'll keep saying this, the kidneys have already done their work, and once they've made that urine and made us well, it's our body's job to get rid of that stuff. And so urine sloshing around back and forth is not a great thing for us. And so there's a couple of valves here. Anyone who's had a kidney stone may know that these valves can get pretty snug, and this is a classic place where kidney stones get stuck. Now we're going to zoom down to the lower half of these images, and on the left here is the male pelvis featuring a prostate. And if you can see me swirling my cursor around, it's just below the bladder here that you pee right through the prostate. Hugely important for much of our lives in urology and much of many of our lives of those of us who harbor prostates and have to try and pee through them. Below that is this ring of muscle, and this ring of muscle we'll call the pelvic floor or the sphincter. Basically the same thing. And in the male pelvis, this is really strong. Some in the call will understand that if someone kicked in the door while you were having a pee, you would have a very strong reflex to be able to stop that urine from flowing, almost like a clench down there. And that's because only two things pass through in the male pelvis, and that is the urethra and the rectum. In the female pelvis over on the right, we have to accommodate a third place, and that's the vagina. And the vagina is the birth canal. And so it has to technically be able to try and accommodate a baby's head moving through it. So that has to be a bit of a weaker muscular floor down there. The sphincter muscle is thinner and a bit weaker by design to allow for carrying of a fetus and passing the baby through the birth canal. You may understand then that if you've got 3 holes instead of 2 and one of them is meant to distend, you may actually have a weaker pelvic floor. And we're going to see some consequences of that tend to happen in the female pelvis a lot more than the male pelvis when we talk about what could possibly go wrong. I'm going to show you a next picture. I don't want anyone to get wound up with a neuroanatomy here and reading all these things. But I think it's an important thing for us to know that the bladder is not autonomous. The bladder does not work on its own and fill and have a pee. It will, but it will do a bad job of that. We see this in our patients and friends who have spinal cord injuries. Those people still have a bladder that fills and empties, but it functions generally quite poorly. And I'll elaborate a little bit on that with a story in a few moments. The important things to know here is that the bladder does not work in isolation. The bladder has a series of nerves. This is the electrical wiring of the body that allows the signals from the brain to say it's okay to pee to make that happen. And this is obviously what's happening inside the bathroom or wherever you choose on the 14th green in the bushes to have a pee. These wiring is important for the signals. The spinal cord is a conduit for those wiring. And then the brain really does the thinking up here. And I'll explain a bit more about that in a moment as I get away from this slide. And then there's a strange thing here you'll see called Pontine Micturition Center. Only good for winning at Scrabble for now. But basically, that's the switch that says the bladder can squeeze and the sphincter or the bladder outlet can relax so that you can let the urine out of the bladder under a low pressure. And so we get to the bladder's actual purpose. And this is going to sound pretty simple, and it's exactly how I teach our medical students, exactly how I teach our senior residents about to be urologists. A good way of thinking about what the bladder's job is. 1, hold on to the urine. That doesn't just mean be a little storage vessel like a thimble and store it for a few minutes here and there, like your saliva when you're chewing your tobacco and have a spit. It needs to hold urine for a while. And we need that to happen with low pressure. Say it for a 10th time. The kidneys have already done the work of keeping us safe. That urine is meant to go down and not back up the hydraulics of the urinary tract. So the pressure has to be low as it fills up. It has to fill up usefully and enough. And if you're looking for a number, I'm going to hold my Tim Hortons up here. It's about that much as a full bladder, about 400 to 500 cc's. We also want that thing not to leak. It's not very useful to be filling up if it's dribbling and drizzling all over the place. It doesn't fulfill its intended jobs. Bladder's only other job is then to empty completely. Once the bladder's full and it's time to go and it's safe to go, we want the brain and the bladder to correspond so that you can go and empty the bladder completely. You don't want to leave much behind. You filled it up, and again, the kidneys did the work, so let's get it out of the body. You may find yourself thinking about some of the problems that may happen here. What if the pressure's high? What if the capacity's low? What if it leaks? What if you don't control the time of your peeing? Some of you may have experienced this at times in your lives, and this is what urology is in my life. So let's talk about this brain again. We're going to give the neuro lesson about why we pee, and hopefully at least message the fact that this is complicated stuff. The brain plays a huge role in peeing. The brain allows us to sense that fullness, just like the brain allows us to feel where we are in space and feel things like pain and temperature. The brain allows us to sense our bladder. And in fact, our bladder is always sending signals up to the brain. Usually the brain's job is to say, thank you for the information, bladder. It's not the time to pee. We're not in a bathroom. You're in the middle of giving a talk, Mike. You are just peed 5 minutes ago. There's not much left in your bladder. Usually that suppression happens. And then the brain also says, okay, it's time for us to be able to pee. And so we're going to have all this stuff up here in the thinking part of the brain, which allows us to not be like a baby who pees wherever and whenever it pleases because that brain is underdeveloped, or in some illnesses of the brain, which I'll describe in a minute. The next part is called the brain stem. The brain stem, you may think of terms like the lizard brain or the primitive brain. The brain stem is what allows us to breathe and be conscious and to sleep and have all of the automatic functions that we don't have to think about, like our guts working and our lungs moving. These things are automatic and they're taken care of in the non-thinking but critical part of the brain. And that is the area that coordinates urination, because coordination is important. If you have a pressure building up in a balloon, but you're holding it closed, all that pressure is just building up. But if you want to squeeze a balloon and let your hand go so that the air can go out, that's what a control is. And so that coordination means that the sphincter muscles or pelvic floor have to relax and the bladder has to squeeze at the same time. And that coordination happens below our thinking level. So the brain says go, and the coordination center says, okay, set the switches, and we're allowed to urinate. And then finally, the wiring down through the spinal cord and into the pelvis, which comes out of the same spinal cord that comes to our legs and comes to our arms, feeds down into the bladder. It sends the nerve signals back up about fullness and discomfort, and it sends the signals back down that it's time to pee. And that is the slightly more complex than you might have figured neurology of voiding. It's not just a bladder filling, saying it needs to go and going. A lot of things have to happen. And so here we are. We've got our cortex, our thinking brain, our brainstem, our switch, our bladder, which fills and empties, and our sphincter, which holds the urine in or accommodates its flow. And as the bladder fills, it's quiet. The bladder wants to be passive and filling and stretching with no pressure. The sphincter muscle has to stay tight because as that bladder fills, it gains weight and the pressure slowly builds and we don't want to leak. The brain is firing, and it's firing a negative message. It's saying, hold, 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 not the time to pee right now. And the brainstem is quiet because of that. And then the bladder gets very full. And that switch from a sense of fullness to a sense of urge happens. And we call it urgency when you can't defer it much longer. And you find yourself available of a time to pee. You finally find the toilet, stand or sit, and the brain says, fine, I'll go quiet. The brain stem says thank you and flicks the switch. The bladder then squeezes, the sphincter relaxes, and we void. Any one of those things can go wrong, which is why we would ask, what could possibly go wrong? Possibly go wrong. Well, let's look back. A good model I have for my medical students, for my trainees, and something we imbue with the patients as well, and myself when I am a patient, is whatever the physiology anatomy is, something can go the opposite. So if our bladder's job is to store urine and our bladder's job is to empty urine, then we can classify the trouble with our peeing as a failure to store and a failure to empty. Again, this sounds a little simplistic, but this is absolutely in the textbook of urology, Campbell's Urology. This is the best scaffold upon which all of us to think. And I tell our trainees, you can figure out a lot about someone's peeing trouble within a couple of minutes when you figure out whether it's a problem of storage or a problem of emptying. And we know that we've got a bladder and a brain and nervous system that create the filling and the emptying. And we know that we've got an outlet, a pelvic floor and a urethra that are the place that shoots the pee out. And so when you have failure to store or failure to empty, it can be because of problems with the nervous system and bladder or problems with the outlet that are allowing it to leak. So let's go through these 4 things. Failure to store. We'll call this one failure to store because of the outlet, and that is incontinence. Incontinence is the leakage of urine. That bladder's job is to fill and stay tight and not leak urine. And when that doesn't happen, that is urinary incontinence, the leaky faucet. And it's common. If I surveyed 65-year-old women, I would probably find that 2/3 of them have some urinary leakage. Men, much less common, as I alluded to way back when, because the pelvic floor in women is necessarily thinner and weaker to accommodate the birth canal, and therefore doesn't have the strength, especially through aging, that allows things to leak. And so, those who've been pregnant a few times, not necessary, but certainly a risk. Certainly those who've had childbirth through the birth canal. People who are menopausal, the change of life robs hormones locally, the muscles thin out. As the years go by, menopause implies making it to 50 and above most of the time. The pressure of all those years of standing upright bows downward on that pelvic floor through weight and causes to stretch and weaken. And some people who've had surgery or radiation to the pelvis will have some scarring that holds that urethra open. Instead of a nice supple tube, it's like a stovepipe that drains. So what can we do about this type of incontinence? Very briefly, we can try to exercise that pelvic floor. You may have heard the term Kegel exercises or pelvic floor physiotherapy, squeezing and learning to control these muscle groups so that they are stronger, so that when you laugh or cough or sneeze or lift, you're able to contract that muscle and its tone is a bit stronger so that you're likely to leak less. We may have things like pessaries, and these are small rubber devices placed inside the vagina that just act as a strut and support the tissues and compress them a little bit to try and prevent leakage. And we may have to resort to surgery sometime. An abstract picture here, but you see the bladder and the urethra, and basically we can place a hammock underneath the urethra so that when one does laugh, cough, sneeze, or lift, the urethra is squeezed against this hammock, and instead of pulling open, it's squeezed shut. That's the basics of incontinence management. You can also fail to store urine or be incontinent because of some overactivity. That bladder may be smaller or maybe more sensitive than someone else. We all have different things about us. I have size 12 feet, I have a bald head and blue eyes. The next person I see may have rich chestnut hair and small feet and green eyes, and so on and so on. And that includes our bladders and our fingernails and our stature. So some people just have a small bladder. They feel like their whole lives are spent running to the bathroom because they can't accommodate it. Sometimes it's normal. It doesn't feel normal when it's not what you're seeing in everybody else. If someone's had pelvic surgery or radiation, they may find that that bladder is more spastic. It's more like leather. If you had a sunburn on the bladder, if you imagine, from radiation therapy, it feels a little less elastic and a little bit more spastic, so it doesn't fill as much. Anyone, and I bet you there's someone on this call who's had a urinary tract infection before, feels that urgency and frequency to void. We call that overactivity in that setting, and hopefully it goes away. Those who've had dozens of infections may find that their bladder's a little bit smaller and a little bit more scarred. And indeed, the bowels can infect things as well. Those who are constipated and have a burden of stool in their pelvis, that pelvis is only the size of a cereal bowl, and it's going to squeeze that bladder forward and create a smaller bladder than there would be otherwise. Now we're back to this picture again. My gosh, we're pointing up at the brain now. Remember, the brain's job was to say no to peeing until it's the right time. The bladder's full and the situation's right. I'm going to show you a list of diseases that you may be familiar with the names. Parkinson's disease affecting the brain. It's a mobility disorder. Multiple sclerosis, which affects the brain and the spinal cord, often in younger women. Dementia, a scourge in anyone who suffers with it or cares for those who do. Strokes, and just general aging and the atrophy and the wearing out that happens. The skin gets weary, the joints get weary, the brain gets a bit thinner as well. All of these things mean that that signal to the brain, which is normally saying don't pee up here, can be lost. And if that signal is lost, what happens is that the brainstem stays quiet while you fill, but you can't fill much. And the slightest shudder of your bladder or the slightest capricious breeze in your pelvis means the bladder asks the brain if it's time to pee. The brain doesn't answer. and the bladder and the brainstem say, thank you. And then it's time for the action to happen. And what happens is your bladder works, and then your bladder's empty and it fills up just a bit, and then it works again. And then you're walking through the grocery store and it works again. And then you just got back to the couch and it works again and again and again. And if the pressure builds up enough, it overcomes the outlet and you have urge-related urinary incontinence, a huge amount of what we see. And when we think about some of these disorders when they're being diagnosed, the urinary tract often doesn't make the first cut. Very briefly, spinal cord injuries. They're important things, and I won't minimize them, obviously. But the spinal cord injury means that the coordination can happen. The sphincter's supposed to be able to relax. The brain is supposed to be able to squeeze the bladder, but the signal is lost. And when that happens, the bladder squeezes against a closed sphincter. And in the annals of history, it used to be that people with spinal cord injuries died of kidney failure very soon after, within years after their injury. And only when we discovered this fact about urination could we catheterize and manage people's bladders and keep people alive for much longer. So what do we do in these situations to try and manage them? Well, management always starts with what you can control. If you have fluid intake that's impairing your kidneys function, so lots of coffee making your bladder overactive, lots of alcohol making your bladder overactive and having diuretic effects that make you pee, you're going to make more urine and you're going to aggravate that overactive bladder. I'll tell patients all the time, I'm not here to rob you of your coffee. Just understand that it may have a role. And those who drink tons and tons and tons of water, often because I've told them to, find that everything that goes in must come out. So managing those things, especially around the evening, is important. And then we've got medications. We've got medications that specifically target two type of nerve receptors on the bladder to try and force a little bit of calm. They come with side effects of dry mouth and dry eyes and constipation. So we can only eke out a little bit of benefit there, but often it's enough to make people feel better. And we have workarounds as well. Sometimes using a depend or another undergarment, sometimes protecting the bed with a sheet is what we do. And when things get really wild, sometimes we take a page from our cosmetic brothers and sisters, and we use Botox in the bladder, a muscle paralyzer injected into the bladder wall to calm things down. And when things get really scary, we can actually use pacemakers in the bladder. There's only a few people in the province who do this, but when all else fails, we can sometimes attempt to stimulate and regulate those nerves. Off to the failure to empty part of things while we wrap up our chat here. Failure to empty comes with a spectrum of symptoms that we know as fun-wise in urology, and all my medical students will recite this. Frequency of urination, going too often, urgency, the inability to defer the sense that you suddenly need to void. Nighttime peeing, a huge scourge. Peeing in the night means tired in the day. A weaker stream, we're getting to the mechanics here. A sluggish voiding. Straining to get things started because you got to get a head of steam to overcome that outlet. And feeling like just you're done peeing, but you know you didn't empty your bladder. Last trip down this picture here, we've got the final wiring on the way to the bladder. If that wiring is injured because it's trapped after a disc slips in somebody with severe lower back pain or facet arthritis in the back, narrowing the space that those nerves can run through. Somebody with diabetes, with organ damage, especially those with neuropathy and kidney dysfunction, will also have nerve damage to the bladder. Those who've had surgery to the pelvis may find that rectal surgery or that uterus surgery has pinged some of those nerves on the way by, and the bladder simply doesn't have the strength to contract. We don't have a lot to do about this. We cannot make the bladder stronger with medications. We can sometimes use catheters, and we can sometimes just monitor the kidney function and make sure things are all right. And lastly, failure to empty, and this is the outlet. The two biggies in this world are overactivity and incontinence, and failure to empty your bladder because of the outlet. This is a fancy way of almost always saying your prostate is getting in the way. You got to pee through the prostate. I don't know who designed this, but it's got some good effects because it allows the products of conception and the semen to go out the right place, but you have to pee through the same tube. And as that prostate grows in the 40s, 50s, 60s, and beyond, it squishes that passageway, much like this gentleman's hose is over the end of the thumb. And that can be a problem for symptoms: frequency, urgency, nocturia, weak stream, intermittency, straining to void, and incomplete emptying. But we also have to remember, as I said, the pressure here. The urinary tract is a hydraulic for my engineers out there. Don't I am not an engineer, so don't come at me too much. But it's not a metal tube, but it's a hydraulic system, and the urine is supposed to flow in one direction. And when that bladder is overfull and the pressure builds, the kidneys can't do the work that they're intended to do. So how do we manage this when it's usually the growing prostate that absolutely some people on this call will have? And I remind you, I don't see any of your names. We can manage our fluid intake. Just try to make the problem less. Try to make our nighttime peeing less by limiting our fluid within 4 hours of bedtime. Drink enough that we're hydrated, but not so much that we're forcing the issue. Take pills, different pills in this case, pills to relax the prostate, to open that passageway and allow the flow through. Pills to shrink the prostate to do the same thing. And sometimes we get to the end of things and we need surgery. This is a little spring-loaded electrical loop you see here, and this goes directly through the urethra and into the bladder and allows us to work on the inside of the bladder. Sometimes we resort to catheters. This is what a catheter looks like for those who are unable to pee. And when you can't pee, you sometimes need a catheter, hopefully temporarily, till we can get you back to the operating room. And sometimes it's a good idea to open someone's prostate up. Sometimes it's a not great idea. So sometimes I'll say, opening up your prostate is like reaming things out. And that's meant to have a significant guttural, visceral feel to it. Reaming out the prostate doesn't sound great. And when I'm not so keen, I tend to find myself using words like that. When I think it's a great idea, I'll say it's like lathing out or whittling out the inside of your prostate so that we can open up the passageway and get things flowing. One way or another, what we're trying to do is look into the bladder. And what you're seeing in top left in this picture is someone trying to look into the bladder from the middle of the urethra and seeing these big bulges getting in the way and slowly working their way through to block off or unblock the passageway so that there's a nice dark passageway in here. This is called a laser enucleation. One of the things we're hoping to try and bring to Kingston, absent the fact that the technology is as its own standalone device, and we're trying to work to figure out our way to obtain such a thing for ourselves here. And finally, the last thing I'll say, because it is the most important driver of quality of life, is waking up at night to pee, called nocturia. The urologist gets the referral for nocturia because it's a peeing problem. I get up too often in the night to pee and I'm tired. But it's not just a peeing problem. The mechanics of voiding happen all the time. You still have to have the bladder filling and emptying like I mentioned. But in this case, it's oftentimes the fact that you produce more urine in the night. There are some hormones that act on the kidney that allow water to spill in the night as we get through our 40s, 50s, and beyond. The heart pump can oftentimes get a little bit less and a little bit less, and especially in those with sleep apnea, can release its own hormone. And if there's extra fluid hanging around during the day, then that fluid gets into your bloodstream at night. This is supposed to be a leg here. ChatGPT gave it another joint, but a swollen leg during the day means that when you lie down, that fluid redistributes. And people with poor quality sleep, from arthritis, from hot rooms, from general low quality sleep like insomnia, or for sleep apnea, have a lower threshold to wake up when that bladder's full and you're up again and again and again. How's this for a whirlwind tour of the bladder? I really do thank you for your attention today. It's always one of my favorite things to zoom out to the fundamentals of things. And I thank you especially for yourselves and for being yourselves and being so key to the fortunes of the UHKF.
Thank you, Dr. Leveridge. I'm wondering if there are any questions. I don't see anything in the Q&A. Oh. Do you want to respond, Dr. Leveridge?
Is there a question somewhere? I don't see it. Oh, I see a hand up.
Yeah.
What do I do with a hand up? Oh, there's something coming in the Q&A now. Why is pee yellow? That's a good question. Ideally, I will say this: if you're aiming for something, you should be aiming for a pale straw color. I say Michelob Ultra or something like that. So pee is yellow mostly because some of the protein metabolic components in it They're not really pigmented that way, but that's how they stay in the light. David Walker, tell us more about TURPs. Absolutely. TURP is a mechanical way of opening up the prostate. It stands for transurethral, so the camera's in the urethral, resection of prostate. TURP. The average 65-year-old probably knows someone who has had a TURP. When medications are either intolerable at trying to open the prostate or simply don't work enough, or if people are getting into trouble like kidney dysfunction or bleeding or things like that because their bladder doesn't empty through that enlarged prostate, a TURP is a way of going inside and systematically whittling or carving out the inside of that prostate so that the prostate is more open. It's a procedure that does mean a hospitalization and carries a bleeding risk afterwards. We can't sew inside, so we can only spot weld and cauterize the areas that are potentially bleeding. But most find their urinary stream improves after that. There's some ejaculation side effects that happen as well. But a TURP is a surgical maneuver to open up the prostate. It doesn't make the bladder stronger. I tell folks it's like taking bricks out of a wheelbarrow when you're having trouble moving that wheelbarrow across the lawn. It doesn't change the person who's lifting's muscles, but it makes the load easier to carry. And so when the bladder contracts, however it is able, it contracts against less pressure. Male here, peeing, standing, or sitting, what's best? What's best is what's cleanest and what is easiest. There is no better position for one or the other. The resistance is generally low. Some people do find that when they sit, they pee a little bit better or worse than others. If I have a large prostate that may kink, but there is no best practice in this case. If the pee dribbles out of you, or if it takes 4 or 5 minutes, then sitting is totally cool. I often have men in my clinic sort of sheepishly admit to peeing while sitting down. And I say the key thing is that you get the urine out of you. So sit down if it makes a difference for you, especially if there's a spraying stream or a dribbling stream. How often Botox prescriptions? Botox, not super commonly. My colleague, Dr. Steele, is our Botox maven in the department. He probably still does have a good few dozen patients in the region who are on his retinue. Botox is an annuity. It has to be done every 6 to 9 months because the effect wears off, which is good. You don't want a toxin that is forever. And Botox carries its own set of risks. When you try to therapeutically stun the bladder once in a while will respond with therapeutic paralysis and be unable to void. So it's a good conversation to have for those people, typically who have failed medications and whose overactivity, urgency, and frequency is dominating their life. Can you train yourself not to get up and pee in the night? Boy, if you can figure that out, Yvonne, let me know, because I have not figured that out myself, and I'm younger than most of the people who come to see me about it. The things you can do are try to dry yourself out a little bit. So fluid intake is good, but I tell people who have trouble with nighttime peeing to make sure that you're avoiding or you're drinking very little, just enough to slake a thirst or take your pills within about 4 hours of bed. Consistent sleep hygiene is out of my job as a urologist, but I still know about it. Comfortable bed, cool room, making sure that you're getting yourself off to sleep and as deep a normal sleep as you can. Those people who have medical conditions that may predispose them to having more fluid in the night, so sleep apnea, people who have what's called edema or fluid on the legs, those people are best served by managing those things as well as possible. We find a lot of people with sleep apnea, which is this waking up to snore, and some people will wear a device. Oftentimes, those people will be waking up a ton, and when they start their journey with their CPAP device, find that things have improved dramatically for them because the depth of their sleep matters as well. Any hope for urgency help other than what we've said? Watch out for yourself. You know yourself better than anyone else, and that means identifying when things are worse or not. If it's worse when your bladder's really full, timed voiding to make sure you're emptying your bladder on a schedule so you're less likely to get into that trouble. Sometimes the real trouble with urgency is that it happens when you're not at home. So making sure that whenever you pass by a bathroom, publicly or otherwise, go for a pee. If you're going to sit down and watch a movie, go for a pee. If you're going to leave the house, go for a pee. If you're going to leave the restaurant, go for a pee. At least the urgency is less likely to happen when you're out in the wild. There are medications for urgency for those who are dominated from them. Again, not magic drugs, but they can often get us from the place where the urgency dominates our lives over the fence to where we can. So there are options out there. Mr. Brooks, a very astute, a pig to human transplant did make the news. Bladder transplant. I'll tell you, bladder transplant or bladder replacement seems like the lowest hanging fruit. We don't need a bladder to function in the way we would need a heart or lungs or a kidney or a liver to function. They have to have all the functions. That's why a transplant helps. A bladder really just has to be a bag that controls the urine, and that would allow someone maybe even to catheterize themselves. Ideally, a bladder transplant that works to pee. The short version is it's almost certainly been tried and it hasn't functioned very well. The problem with bladders in this case is that they water finds a way and they will tend to leak or scar where you've plugged them in. Which is something at the hospital here. I'll mute for a sec. Another key factor is that the blood supply to the bladder is very variable. It's a bunch of small blood vessels rather than one main artery and vein, which is a feature of the other transplantable organs. So technically, there's not really a place to put it properly. But for whether it's building a fake bladder out of one's own stem cells or transplanting, one of the main issues is the rejection happening. A bladder that's transplanted wouldn't function because it has none of the nerves that a native bladder has. So really, you'd be talking about a reservoir that you'd be able to catheterize and drain or strain and relax the pelvic floor. They tend to break apart and they tend to scar at the area where you've sewn them together, which is a real problem because you can't get a catheter in from there. But again, I share the sentiment that it should be one of the easier things to replace because it just has to be a bag. How often should I see a urologist? Prostate meds, but saw very long ago. If you are stable and have a reasonable, steady state of your urinary symptoms, not getting worse, if you have a primary care doctor and a relationship with the same, and I know in Kingston that is, and environs that is certainly not a guarantee, then staying the course is very reasonable. Having long-term check-ins is not necessarily necessary. Oftentimes, the best move is to get into the care of a urologist if you require some thinking and some strategizing, and once reaching a steady state, fall back to the primary care. And then if there's a change, then back to the urologist. And sometimes urologists will follow people just as a matter of routine. What does this kind of machinery cost, Mr. Jenna? I think you may be talking about the machinery for the laser opening that I mentioned. The number is something like $154,000. The technical stuff is a laser and some scopes that are proprietary. And then there's a thing called a morcellator, and that morcellator basically is a machine that with little teeth that spins around. Because when you plunk big hunks of prostate into the bladder during this thing called enucleation, you can't pull them out because they're too big. So you have to have this machine called a morcellator to go in basically and grind them up and suction them out while avoiding harm to the urethra or the bladder. It's something that is emerging in urology, and there are a handful of people who've done zillions of them. And in Ontario, there's about 3 or 4 people who really have it as part of their practice, and it's slowly starting to build up because the learning curves are reasonably high. Mr. Brooks, I think we spoke about the artificial bladder as well, and I think it would be some of the lowest hanging fruit if we could. Urgency when the bladder isn't very full. That is almost the definition of urgency, Lindsay. Urgency when the bladder's full is just a full bladder. Urgency is almost always when the bladder's not full. And that can be, again, anything from the spectrum to a small bladder or an oversensitive bladder, someone with a urinary tract infection, rarely other diseases affecting the bladder, some of those neurological things that we talk about. So we'll often have a few questions about red flags to make sure that we don't think there's anything sinister going on. And I would reassure you that it's very rare for that to be the case. But for those who do have a known diagnosis, like what we talked about, those in stroke recovery over years, those with Parkinson's disease or anything like that, it's very, very common. Oftentimes we don't figure it out. One of our jobs is really to identify the red flags and the dangers, and then if we can't find the red flags or the dangers, we just make sure things are as healthy as they can be and then hope that we can help people accommodate to their grief. When to use the pacemaker? We call this the interstim device. That is at the end of a pretty long chain for specific people who are helpful for it, either neurologic disease or not. Overactive bladder, that is what we say recalcitrant, does not respond to treatment. So those people who have tried all the trigger management and the timed voiding, the medications, and they're still having trouble with a bladder that simply won't cooperate and really is dominating their quality of life, those are people we'll send for a consultation around the value of the pacemaker. Why do people with sleep apnea have more fluid? It's a few things. One is that the sleep apnea episodes, which are like deep snoring, that's a high pressure situation. If you are trying to breathe out against a snore, then the pressure in your belly builds up. That pressure builds up and prevents some of the blood from flowing backwards in folks who are having apnea episodes frequently. It also creates, through the pressure, the release of a hormone from the heart. And the release of the hormone from the heart tries to say, hold on, there's high pressure here. The best thing I can do is try to get this body to pee more so that it's got less fluid in it, and that drops the blood pressure. So there's a hormone called BNP that happens in those cases. And could you speak more about Kegel exercises? Kegel exercises, and I would say find something that says .org on it. The Mayo Clinic and UCLA, as in University of California, Los Angeles, have good online resources. They do take a while, and it's not just 5 or 10 little flicks. This is like lifting weights. So they take a prescribed course. So attempting to do them at home is a very, very reasonable, zero cost, zero risk thing to do. But really you want a practice of squeezing and squeezing. And there's two things that this benefits. So even if it doesn't work to dry you up very quickly, and it doesn't always dry people up, it gives you an awareness of that pelvic floor. And so people who do leak will often know that it's when they're laughing, coughing, sneezing, lifting, that is going to happen. And so when those folks are about to lift or cough or get out of a chair, their awareness of that muscle through their Kegel training at all will allow them to squeeze and hold while they make that transition or while they get through that sneeze, and then relax that muscle. And that can often help minimize the amount of leakage that's happening. There are formal things called biofeedback and pelvic floor physiotherapy that can really sort of amp things up for those who need them. Indwelling catheters are for those who can't pee, as in if you can't pee at all, you need an indwelling catheter. That is a catheter that goes through the urethra, sometimes through the lower abdominal wall, into the bladder to drain it completely. So if you're unable to pee, some people are able to pee, but not enough. They may feel like they're doing the job, but when we look, their bladder is still quite full at the end of the void. There's still 200, 400, 800 cc's. And if there's a lot in there, and if the kidneys are showing signs of strain because the pressure in the bladder is there, then catheterization for a period of time is necessary. But the classic is that somebody needs an indwelling catheter when they're unable to pee. Changes are typically in the 4 to 6 week range. And I encourage people with a catheter, there's not a lot of good to having a catheter, but it does mean you don't have to go for a pee. So I tell people who have a catheter, take this opportunity to drink a lot of water because you won't have to worry about getting up in the night. You won't have to worry about running to the bathroom, and you can help keep those kidneys flushed and keep the catheter as clean as possible. And John, is there a normal number of times peeing at night? Short answer is no. I mean, the optimal number is 0. I was stunned when I met somebody in the clinic today who's 75 and doesn't wake up at night because that is very, very rare. So normal is 0. Typical kind of varies. So I would tell you that a man in his 50s who says he wakes up once at night, or a woman in their 50s, I say that's pretty par for the course. 60s, 1 to 2 times, pretty par for the course. 70s, 2, 80s, 2 to 3. For some, it's every hour or more that they're up in the night. And as I say, it's a real driver of people's quality of life. So there's no great normal number. It should be that we sleep as long as we need to. But there's a few variables there, and there's some typical numbers. Really, the question is whether your quality of life and happiness are bothered terribly by them, unless you're an airline pilot and you really need to not be waking up at night. But for those who are suffering from the fatigue, for those who cannot get back to sleep, that's when it becomes a bit of an issue. And as I say, it's a tricky nut to crack. You come to the urologist and we offer our blunt tools like a drug to help you empty your bladder a little bit better, where we know it's a combination of sleep, fluids, cardiovascular issues, arthritis issues. If you have an achy shoulder lying in bed, you're likely to wake up just to wake up and turn and remind yourself that you need to pee. So there's a dozen things that come into to nighttime peeing, and it's a real challenge.
Thank you, Dr. Leveridge, for trying to simplify a very complex process and answering our questions so well. The video, as I mentioned earlier, will be available on our website and YouTube if you want to watch again or share it with your friends and family. Thank you all for joining us today and for your continued support of our healthcare facilities in Kingston. Don't forget to play the UHKF 50/50 lottery. This month's jackpot deadline is April 25th at 11:59 p.m. Maybe while you're contemplating getting up to pee, you can go to the computer and log on and get some tickets. Before that date, there are 2 cash prizes that will be drawn on April 12th and 18th. And my favorite time of year is coming up with the annual Tim Hortons Smile Cookie campaign. And that's taking place between April 29th and May 5th. And they're delicious frozen too. The proceeds of all the cookie sales at Tim Hortons restaurants in Kingston are going to support child and youth mental health programs at Kingston Health Sciences Center. And last year, the Smile Cookie campaign raised $230,085. Wow. Tim Hortons will be accepting pre-orders starting on April 22nd. So visit our website to download the form. We also need volunteers from 7 to 9 a.m. on April 29th to encourage customers to purchase a Smile Cookie at all Tim Hortons locations. There are also opportunities to decorate Smile Cookies from 4 to 6 every day that week. You can call Gary at the UHKF office, 613-549-5452, extension 5915 to sign up and help us make another record-breaking Smile Cookie week. Thanks again for joining us today. The next Circle of Care event is scheduled for June 26th, and it will be an in-person luncheon at the Cataraqui Golf and Country Club. Dr. Omar Islam, Department Head, Diagnostic Imaging at KHSC, will be talking about innovations in radiology. Look for your invitation to arrive in May, and I hope to see you there. Enjoy the rest of this lovely afternoon. Thank you all.
Thank you so much.